Hello, my name is Amanda Porter. I'm in the Department of Bioethics at Dalhousie University, and I'm very pleased to be participating in this NCHEN conference for 2020. Today I'm going to be talking a little bit about just sort of summarizing the major ethics issues and some lessons learned in the COVID pandemic so far. It's a little funny to be talking about lessons learned in this pandemic, given that we're still in the thick of it. Indeed, yesterday was the news reported that it was the global record for new COVID cases in a single day since the beginning of the pandemic. So again, I expect there will be very many more lessons learned yet, but hopefully this can be an interesting summary of sort of ethics issues that have arisen to date. Some have reflected on what changes have resulted during this pandemic that should be temporary, and what changes have resulted that we should hope to continue or even expand on. So things that we probably all hope are temporary are obvious, things like social isolation, unemployment, having to wear masks, slowdown in certain health services. These are all things that we're hoping we can overcome. But some of the things that have been noted as positive changes in our health system include things like the more widespread routine adoption of virtual care or telemedicine in certain contexts, greater funding and some structural changes to long-term care in Canada, a reduction in the siloing of health services in the sense that institutions or units or departments that previously didn't work well together are now collaborating well. Renewed prominence of public health in healthcare in general. Sometimes I think public health has been relegated to, it's received less sort of popular attention than other areas of healthcare. Growing prominence of the role of data and evidence in our public decision-making and respect for those who produce this knowledge. I think also growing attention is now being paid to the mental health and well-being of healthcare providers and first responders, and I think these are all excellent things worth continuing. Just adding to that list, I think there's a couple other things that I think we have shown glimpses of during this pandemic that I think it would be worth continuing and expanding on. One is what I take to be greater use of empathy and our moral imaginations. So I think many of us have been required to creatively imagine ourselves or to think of what it's like to be another person, often a person who might be quite different from us. So for example, news reports in CBC have asked us, what would it be like to be an older adult or a person with chronic health conditions who's living in a crowded correctional facility right now? What would it be like to be someone who's a newcomer to Canada, who they think their immigration status depends on their continued employment, but they're being asked to work in a crowded condition that seems unsafe? What would it be like to be a high school teacher who has asthma and who's working in a classroom where physical distancing isn't really feasible? What would it be like to be living in a long-term care facility without your family able to visit? What would it be like to be a woman living in an abusive relationship during the lockdown? What would it be like to be a frontline healthcare provider with no childcare available, and then who has to ask an older or more vulnerable family member to look after their child? What would it be like to be an emergency responder without the recommended personal protective equipment? I think increasingly people are starting to exercise, again, their moral imagination. They're asking not just what another person can reasonably expect of them, but what would it be like to be that other person, to be in that context, to have that lived experience? And I think in general, this relates to an approach where we think ethically significant features of situations are often more easily identified, not by the application of principles and moral theories, but instead by narrative, through storytelling, through exploring a situation and kind of uncovering its ethically significant features and values and principles. So I think we're doing this a little bit more than we used to. And I think it would be great to continue doing that. This moral imagination and expanded empathy, I think, raises the question, whose stories are we hearing and whose stories are being left out? And I think this leads to a second positive change that I think I've seen in some pandemic work that it would be good to expand on. And this is the valuing of inclusion and diversity at decision-making tables. So it's often been said that we're all in this together, or we're all in the same boat. And pretty quickly, people identified some challenges with that view. As nice as it was sort of oblivious to the context that some people were living in. And so some people responded by saying, well, it's the same storm, but we're all in very different boats. And some of us are in yachts, and some of us are in crowded life rafts with holes in it. And I think this has resulted in some instances in a greater diversity, inclusion of perspectives, exploring things from the perspective of more vulnerable groups. Not universally, but I think there has been some improvement there. I think that given how easily viruses spread, it's the case that if anybody in our society is at risk, then we all are. And so in that sense, it's been kind of easier, relatively speaking, to motivate other regarding concern because we're also intricately connected in this obvious way. But I think it would be interesting to reflect on whether we can preserve this other regarding concern and inclusivity, even when the physical well-being and survival of those in socially dominant or powerful positions in society are not so obviously connected to the physical well-being of those in more socially or economically marginalized communities. So I hope so, but it's just something to flag. In terms of the main issues that I think have been faced by the health system, planners and policymakers within it, these are some of the key ones, I think. The health system has to confront the vulnerability of the health system to continue operating in the event that large numbers of staff become sick or have to quarantine. And this is especially serious in areas where the care is specialized. And so the care that's provided replacement workers couldn't be easily found. So the significance of, and that might be not necessarily due to a pandemic, it could be due to a fire, it could be due to some kind of natural disaster. So sort of the vulnerability of the system to mass loss of its human resources, I think is really been flagged here. I think the health system has also had to recognize the value of having a provincial system where we can, as needed, move patients around within the system, and as needed and as possible, move staff around to improve the accessibility of care and reduce disparities if and when resource shortages arrive and become drastic in certain areas. So the value of having a coordinated, centralized provincial system, I think, has become more clear in this pandemic. The growing need, this has been a long-standing issue, but the need for one person, one record, and the benefits of electronic health systems that are provincial in scope, including, for example, our drug information system here in Nova Scotia. The value of these things, I think, has also been made more clear, including their ability to promote continuity of care, etc. I think there's been growing awareness about the importance of not just physical safety, but psychological safety and well-being of healthcare providers. And I do hope, as I said earlier, that I hope this will continue. I think the health system has had to confront how potentially reasonable responses in one area can have significant and unintended harm in other areas. And so, for example, we saw this with the magnifying of the opioid epidemic, where prior to the COVID pandemic, death rates due to opioid overdose were declining, and now we see they've gone up again. So these are obviously unintended consequences, the social isolation and the mental health consequences that have arisen as a result of that, obviously also unintended, but fairly significant. The health system has had to grapple with the increased likelihood of complicated grief that's caused by this disruption to collective rituals and ceremonies relating to dying, death, and bereavement, and grieving in isolation. And for Nova Scotia, this risk of complicated grief has been compounded by the mass shootings that were experienced here in April, along with other tragedies that struck close to home here in Nova Scotia. As an ethics program, I think some of the central issues that specifically have related to my work and the work of my colleagues, one relates more to procedural justice. Typically in ethics, we focus a lot on process. We say, part of what a right answer is determined by whether it was a good process, a good decision-making process, one that was transparent, inclusive, well-informed, etc. But during the pandemic, large organizational ethics decisions had to be made in a short amount of time, a relatively short amount of time. And this raised for me the question, what are the essential components of a fair decision-making process during a crisis? And what kinds of procedural shortcuts are permissible? I think this is an outstanding question. Triage, wide-ranging questions relating to triage were another area of significant ethics work. So when health services need to be limited, who should be prioritized? And how should those prioritization decisions be made? So the example of triage that acquired so much time in newspaper headlines related to ventilators and access to critical care resources. Who's going to get the ventilator if more people need a ventilator than there are ventilators? And while this is a really serious question that I think Nova Scotia has done a good job of transparently exploring and developing a protocol around, there are a wide range of other areas in which triage is happening, both during lockdown and during this sort of recovery phase. So it's not just about ventilators, it's about access to screening, access to labs, all of these things. So how do we determine whose healthcare needs are essential and which ones are not essential? And when we start revamping, starting things up again, how do we manage those wait lists? Another area of significant ethics work has been around balancing the need to communicate and be transparent and promote trust with the desire to prevent psychological distress or worry and compound people's challenges. So for example, an example of this is when and how should triage plans be communicated to the public? And similarly with staff, administrators are struggling sometimes, I think, with the question of how do we ensure that employees can trust the decision-making process, but give them enough detail about that process. So we want them to trust it, but we don't want to give them so much detail that they're overwhelmed. So how much, again, this is about information and how much information is communicated and to who. Some ethics issues that have come up during the COVID pandemic are ethics issues that have come up in previous pandemics as well, and they will just continue to come up in future pandemics. One relates to shifting from concern for individual autonomy and liberty to concern about the well-being of the community as a whole. And so examples of this were things like self-isolation or visitor restrictions, shutdowns, travel restrictions, limitations on the number of people who can gather in one place. In 101 ways, we've all had to had our options limited for the sake of the community's well-being. And these can be challenging, particularly the visitor restrictions in hospitals. Another common challenge that arises in pandemics, and did here as well, is the tension between a right to a safe work environment versus the duty to provide healthcare. So balancing an employee's right to feel safe where they're working with appropriate PPE with the duty to provide care and the duty of non-abandonment. And I think that this balancing act can be complicated by different understandings and tolerance for risk. For example, differences in opinion about whether one is safe using certain kinds of PPE for certain kinds of procedures, or whether one is safe providing home care, for example. And I think sometimes risk tolerance can vary according to the position that we're occupying. So when we're talking about some of these questions about PPE, are we imagining ourselves working in, for example, procurement for a large health institution who is struggling to find a supplier? Or are you imagining yourself as a frontline healthcare provider? I think sometimes, again, use of moral imagination and imagining yourself in different positions can be helpful. Another very common challenge, which I've already alluded to, is resource allocation. And this has come up in previous pandemics, and it came up here as well. Again, not just about who should get the ventilator, but who should be prioritized, for example, for in-person visits. Whose chemotherapy should prioritized if we're trying to limit the number of people coming in and out of hospital, who gets surgery first as services are reintroduced. What's essential? For example, are safe injection sites essential? And we saw in Ottawa the awful story of people actually overdosing in the lineups for a safe injection site that had to slow down its services to preserve physical distancing and these sorts of things. So I think in terms of future ethics challenges, the hills that we've yet to climb, I think the big one is to sustain energy and support for public health measures to reduce the potential that our health system is overwhelmed. I think this has been a marathon, not a sprint, as everyone keeps saying, and that can be difficult to keep going. This kind of the public trust that's necessary and the sense of social solidarity that's necessary, I think may be strained as if and when the economic impacts of the pandemic are slow to recover. So that's a hill I think we'll have to climb. And as well, another one on our horizon is the distribution of vaccine. So I really look forward to future conversation. I hope that this has spurred some thoughts for you. I would welcome hearing from you, and thank you for joining the 2020 NCHEN conference. Thank you.